Good afternoon, students. Sorry this took me to sorry I had to re-record this VidGrid, but we should be up and running for class next week. So here is the elimination and nutrition concepts. This is the VidGrid that ties in both those concepts. So this first concept is elimination that is found in that Pearson Module 4. This is roughly pages around 293 through 358. The exemplars we will be covering are 5A, 5B, and 5C. Those are the BP8s, as well as bladder incontinence and retention, as well as the bladder incontinence and retention, or the other word for bladder retention, or I'm so sorry, bowel retention is constipation or impaction. The exemplars will be more focused on in class, so expect that part of that lecture to more emphasize. I will only just kind of hit some high points, generalized nursing care, things like that, for this first part of elimination. So here we go. So with the concept of elimination, this is that secretion or excretion of physiologic waste products by the kidneys and our intestines. With urinary elimination, this is the solute waste from our body supply. It is obviously filtered through our kidneys. It rids our body of excess fluid, electrolytes, as well as excess liquid not needed for homeostasis. It does kind of, our kidneys do kind of help control that blood concentration and composition throughout our body system. And then our bowel elimination is the unused portions of solid ingested material. Obviously, defecation is when we do expel our feces from our anus and rectum area. Basically, that's considered what we would also, obviously in layman's terms, call a bowel movement or stool. Everyone needs to have a fully functional urinary and gastric tract system to maintain the proper elimination of our bodily waste in order for our body to remain healthy. Alterations in function need to be evaluated and addressed so that clients can return back to our normal function, so that way we can restore that homeostasis if it is out of line. Okay, so our attributes are our main characteristics. When I see attributes, I always try to think of like those signs and symptoms of a well-functioning body system is when we're talking about attributes. So with the concept of elimination, what is those characteristics? Obviously, we want that homeostasis of our bladder and the bowels. We do want voluntary control and regular passage of urine, as well as our routine urge to defecate, along with that regular passage of formed stool. So those systems need to be working properly. We need to be able to control those under normal circumstances. Obviously, do I expect a infant or a 1-year-old to have fully control over their body functions, as in like being able to hold their urine or stool? No. Obviously, we're talking about a toddler or child age that would be expected, and on into adulthood, and then even our geriatric population. Ideally, the healthy individual is able to control those if it is part of their growth and development time frame. Our antecedents, this is what has to happen, of course, for that elimination concept to take place. So in order for our body to properly eliminate, we do need that adequate hydration and intake. We do need to have that peristalsis, especially in that GI tract, to help expel the stool. We do need to have that control of our bowel and bladder system. We need to be continent. And then our bowels need to be able to expel those feces. And then our bladder, obviously, to be able to relax enough when we do need to void and not have that retention. Yep, sorry. I thought I wrote myself a note on this slide, but next slide. So onto our urinary system. This is just a quick recap of that pathophysiology kind of that A&P side of our urinary system. Of course, with the urinary tract system, we do have our 2 kidneys on the right and left side there. Down from the kidneys is what we call our ureters, and that will go directly into our lower urinary tract, which is into the bladder. That does go down to the urethra. and then that pelvic floor area. So when obviously we are urinating, the medical terminology for urination is micturition or voiding. That is that passage of emptying our bladder. Urine does collect in our bladder, and then pressure is what will actually stimulate those muscles and the stretch receptors in that bladder to obviously transmit the impulse to our brain to tell us that we can void that from those impulses that obviously that are traveling up that spinal cord to our brain, telling us that we can relax those muscles in order to void. So our primary function is to eliminate those, again, to eliminate that excess fluid and waste from our body. Obviously, our urinary system does help regulate those levels of electrolytes, produced hormones that are important for our blood pressure regulation as well. And that's more that balancing act with our fluids. Our kidneys do help develop our red blood cells, and they do help keep our bones strong. Because what is it doing with the calcium? Is it pulling with that osmosis? Are we pulling certain electrolytes in and out, or minerals in and out of our bloodstream in order to support other body systems? So our urine does travel through that urinary system. Sorry, I'm kind of repeating myself. Down through the kidneys, ureters, bladder, and then through the urethra. Just a side note, just so you can adequately kind of start getting a picture of what normal should be for an individual. Our bladder can hold roughly about 2 cups of urine. So if you have an individual that is not able to void, and we know that we're pumping them full of several liters of fluid, should we be concerned? Absolutely, yes. So then we might need to calling a physician to, if they are not able to void, talk to them about maybe straight cath, or if necessary, putting a Foley in those individuals. So some other factors that can affect obviously our elimination system from our urinary tract area is obviously the fluid and food we do intake, our muscle tone. So remember that pelvic floor we kind of talked about. Let me flip back over to this. I know this is obviously a picture, but this is probably a female's illustration here, but men also have what we would consider those muscles as well in our pelvis area. Having adequate muscle tone, being able to either not have the incontinence due to poor muscle strength, or being able to relax those muscles as well, so we're not having that retention. We also obviously need factors that may affect obviously our elimination can include psychosocial factors, pathological conditions, surgical or diagnostic procedures can obviously hinder our urinary tract system. One common thing that can be associated with it is sometimes with anesthesia. Some patients, because when we're putting the body to sleep, kind of everything falls asleep, just like our gut in our urinary tract system as well. So sometimes individuals can have trouble urinating right after waking up from anesthesia. We kind of have to wake everything back up. So this is why we can't just feed them immediately after surgery. We have to wait till we can actually hear some bowel sounds, or do they have their gag reflex back? And this is why if you are a day surgery patient, they do want you to be able to void or urinate before you are allowed to leave their day surgery premises. If this was like, let's say, quick in and out gallbladder procedure, they want to make sure that you can pee, that your bladder woke up adequately, you're not retaining urine, and that you're able to void. Certain medications can also inhibit our ability to eliminate. One that I just am pulling off the top of my head, amitriptyline. One of the major side effects of amitriptyline is urine retention. So we just kind of have to keep an eye on those individuals. If it's just, if they're only using amitriptyline, let's say at bedtime, is it that much of a concern if they don't urinate for 6 or 8 hours? Not necessarily, because they're hopefully sleeping during that time, but as long as they're able to urinate the next day once that amitriptyline has worn off, that would be definitely something to kind of keep in mind. Other alterations that can be common that relate back to our eliminations, our urinary system, do include our age-related changes. Obviously, as we age, so does our entire systems. So what is going to happen to our muscle tone in our pelvic floor? Is it going to become weaker over time? maybe for females, if you've had multiple births and as we're aging, could that bladder start prolapse or start sagging, which could contribute to some of those incontinence things that we'll talk about in class. And then obviously we can have some chronic or acute diseases that can interfere with our ability to urinate. Automatically, when I think of chronic, I think of chronic kidney disease. Our kidneys aren't functioning properly, so we actually aren't producing, our kidneys aren't able to make urine. So that's something very concerning, of course. In order to provide high quality care to our patients, nurses do need to understand the alterations in urinary elimination to provide adequate interventions. So I wanted to mention back on, this is where my notes were. I wanted to mention back on the bladder area and that pelvic floor area. There are 3 sets of muscles that do help prevent incontinence or unwanted voiding. So there are muscles around our urethra, as well as the bladder neck has a sphincter. And then, of course, we have the pelvic floor muscles that do help. Either we're hoping our body and those signals to our brain are able to either constrict those muscles when we don't want to void, and then relax those muscles when we are needing to void. Okay. One very important thing, I know those of you that had me for 1128, the intro to concepts, we talked a lot about or we'd mentioned at least in one class about urinalysis. So we're going to dive just a little bit deeper into urinalysis. Don't be surprised if I am going to put a math question on this Unit 2 exam where I will want you to calculate roughly how much an individual should be urinating an hour based on their weight. So remember, if we know an individual's weight, this is how we want it calculated. Ideally, a physician will give us some parameters, but roughly this is what most parameters will look like. We want them to void 0.5 milliliters to 1 milliliter per kilogram an hour. And so don't be surprised if I put that math question like this on our exam. So if you have an individual, let's say that is 10 kilograms, very young individual, obviously, and so we would want them to be able to urinate 1 milliliter. You'd multiply that by that 10 kilograms. So you would want this individual, obviously this would be an infant, you would want them to be able to urinate at minimum 10 milliliters an hour. So we will work on a couple of these in class as well Monday, just to kind of give you a heads up, just to kind of refresh some of that math that we talked about when we talked about, I want to say it was from the fluid electrolytes lecture in 1128. But anyway, so there is a lot of terminology that I really do want you guys to be familiar with, and this is why I am changing the ticket to class that we will have on Wednesday. It'll be a lot of it, will honestly be a lot of terminology, definition and answer thing, because as students and as nurses, we do need to understand if a physician has this in their history and physical, you will be able to understand what this means. So obviously the term polyuria, that does mean too much urine. Signs and symptoms of this do include that intense thirst, dehydration, weight loss. When I see that polyuria, I often do think of an uncontrolled or undiagnosed diabetic. Obviously they can have polyuria, polydipsia, polyphagia. So they can have where they're wanting to take in lots of fluids, they have extreme hunger, and then they're obviously going to have the excess of urine as their body's trying to compensate with the excess sugar that's in their systems. If we are unable to treat that polyuria, it can obviously lead to that polydipsia, and that's why those diabetics will have that, where they are having that extreme thirst, is because we're losing all of their fluid at that point. Anuria is the absence of urine. Anytime you ever see an A on these medical terms, always think absent is how I've tried to remember the ones like this. So anuria means that they're there is an absence of urine. The true definition does say that it can mean that there is a very little amount of urine. So roughly this might be that patient that might be only in stage 1 or 2 of chronic kidney disease. They may be still producing some urine, but it is less than 100 milliliters for a full day. So that is not very much urine at all. Oliguriria means without. The O, whenever time I see a capital O like that, I think of without. So oliguria is without urine at all. This is the individual that will produce absolutely no urine. This is, I'm so sorry. Anuria is what I consider absolutely no urine. Oliguria is just a decreased amount of urine. Don't let that confuse you guys. So oliguria is that decreased amount of urine that is less than that 400 milliliters a day, or that less than 30 milliliters an hour. So the oliguria patient can still produce some urine. Anuria means that we are expecting them not to produce any. So the anuria patient is the individual that probably is on dialysis, and many of those patients do not produce urine, and if they do, it might be like 10 milliliters for the whole day. Where oliguria, we might expect them to still be able to make some urine, but just not enough. Some of the exemplars that we will be talking about in class on Monday will include the urinary incontinence as well as that urinary retention. So those definitions, of course, urinary incontinence is that involuntary urination. It is a symptom and it is not a disease. So especially with our elderly population, would you say that all of our individuals that are in their 70s to 80s will automatically have incontinence? No, not all individuals. That is not an expected part of aging. Do we see it a lot with that age group or that population? Absolutely. Especially if you work in like a nursing home or long-term care setting, will there be a huge chunk of your patients that do have urinary incontinence? Absolutely. But it's important to know, especially for NCLEX purposes, urinary incontinence is not a normal sign of aging. Unfortunately, it is a symptom of something not working properly. Okay. Urine retention, of course, is when that bladder is not able to fully empty and we are actually retaining that urine. I do want to mention that table 5.1. Those are the factors associated with alterations in urinary elimination. I would highly recommend you know those terminologies and what each one of these mean. A couple of these I did highlight here on the slide, but you will need to know all of these. Okay, I think that's all I pretty much got on this slide. So what is our nurse's role when we are talking about elimination, urinary elimination? So first is that assessment stage. So what are we expecting when we are wanting to assess an individual's elimination system? We can obviously get some data from some lab work, and that does include a urinalysis. I would be very familiar with table 5.2. What is normally found in a urinalysis? What means that this is a normal, what we consider UA, and what is abnormal? It is important to know these three things are always considered abnormal in a urinalysis. These include protein, blood, and white blood cells. So if you are positive for protein, blood, or white blood cells with a urine analysis, consider this abnormal. Now, we can have individuals that can have some glucosuria or sugar in our urine. This should be closely monitored, especially when we are talking about diabetics. It can be somewhat of a normal finding for some pregnant women. It doesn't always mean that they have just gestational diabetes when they're pregnant, but sometimes it's just the pregnancy itself can be obviously hard on our system, and they may be excreting a little bit of sugar in their urine. We just usually keep a close eye on them, and as long as we're not having those major spikes in their blood sugars and they pass their glucose tests in their pregnancy, and mostly as long as we're not having things like the protein in their urine, the physician will just usually keep a close eye on them. The other part of our urinary assessment, obviously, is that COCA, and that is there's a giant table on page 301 to 302. It basically is breaking down that COCA, the color, odor, consistency, etc. So make sure you are familiar with some of those assessment things. You guys really do know a lot of these already because you've been able to put Foley's in and explain part of that. Other diagnostics that we may use in the healthcare system do include some other diagnostic tests. I would highly recommend you read these 2 pages. So this diagnostic area does start on page 299, and then there's another chunk of some diagnostic tests on page 336. Highly recommend you reading each one of these. And if I were you, I would write out each one of these tests and kind of write what the purpose of that test is and what is it showing us in that test. For example, we have what we call a post-void residual. I'll talk about this in class when we talk about that urinary retention. So it is a bladder ultrasound, and what we do is we have an individual pee, and then we have them, and then we check their, we take that ultrasound and we actually check to see if their bladder still is holding urine in it. And that allows us to see how much are they actually retaining. This can be very important, especially in labor and delivery. This would tell us if we need to go ahead and put a Foley in an individual or do a straight cast. So that way, remember, that bladder really can only hold about 2 cups of urine. So if we are concerned that they are not able to fully empty their bladder, this is a concern for problems with infection down the road, especially urinary tract infections. So I know these 2 urinalysis, or at least this green one, I did show you guys in 1128. But remember, this is what we would consider the normal urine analysis. Obviously, if you guys see, everything is within normal limits. So we don't have any bacteria, we don't have any leukocytes, we have less than 5 on our white blood count, we don't have any nitrates, we don't have any significant amounts of blood or epithelial cell, and our pH is within normal limits. So this is the healthy individual, healthy UA. On the other hand, this is an individual that obviously you can see there are some abnormalities. So with the appearance turbid, it just means that it's not that nice clear yellow. That's the best way I can describe it. The color is just off. There is +1 white blood cell count, and then they are also showing +1 protein. Then if you guys scroll down further in this UA, you will also see that there was some epithelial cells that are showing up. It is greater than 10, and you should actually have, I believe this one says less than 5. And then bacteria, there is many. And then up here, when we were talking about bacteria, it should be absent, right? We don't want there to be bacteria. Honestly, they did run so what they ended up doing is running a culture off this urine to see what is growing. And unfortunately, this is just a bad catch is what I would consider this. So this means that there is, when they say that mixed flora, and what's telling me also that this is a bad catch where we didn't clean properly before we got this sample, this UA, is those epithelial cells. Anytime I see a high epithelial cell and mixed flora, to me that just means the individual did not properly wipe with those cleansing pads, cleansing wipes, or we as healthcare workers did not get a clean catch from that Foley. It was maybe not a sterile technique. So just kind of keep that in mind. This would be considered an abnormal UA, but we're not growing anything that, like it doesn't say E. coli, obviously that grew. So it is something that a physician would want us to get another urine specimen with this result. He would want a fresh one, and he'd probably want it sterile. So he may either have us wipe the individual to collect it, or if this was coming from the Foley, I've had physicians say I would like them to have a new Foley, and you get that clean catch from the brand new Foley to ensure that that first specimen is somewhat sterile. Okay, so this is just one example that we might see in the real world. So some interventions and then collaborative therapies for our urinary system. So talking about our non-pharmacological therapies, there is a box on roughly in those exemplar pages on 337 to 344. I would highly recommend you be very familiar especially with the different types of incontinence and what we can do without medications, those therapies, those recommendations for those specific types of incontinence. Really make sure that you do read over those sections and kind of understand which ones go with which type of incontinence. Obviously, we can do some lifestyle modifications. This can include cutting back on caffeine. If you have an individual, let's just say they're a nurse, because I know nurses, what do? When we're working the floor, we hold it, right? We're going to hold it for the whole stinking 12 hours if we have to. That is a very easy thing to fix, right? We're going to develop distension. So what do we need to tell that individual to do? They need to take bathroom breaks at least every 4 hours or so, whatever the situation is. We need to make sure they are drinking fluid. So that way our kidneys are able to filter out that waste. We also need to wipe from front to back, especially for females, so we aren't concerned about getting a stool or E. coli into our urinary tract system. Kegel exercises, of course, especially for those females that have had children or those that are aging. We need to rebuild back that muscle strength in that pelvic floor to help the incontinence. We can do something called bladder training for those that have maybe had Foley's for an extended amount of time. Obviously, we can do scheduled toileting. That can be really good for even school age or toddler age in there when they're trying to obviously be potty trained, or if they've had some sort of bladder surgery, we're trying to get them back on a schedule, back on a routine. And then just obviously habit training. Do we want that nurse to hold her urine for her whole 12-hour shift? No, we want her to have her breaks in order to fully express her urine. Skin integrity is something huge, right? If they do have catheters, we need to make sure we are performing catheter care. If we are dealing with incontinence or dribbling, things like that, even our male population, we need to make sure that we either have some certain barrier cream for them, or are they wearing a Depends or diaper? Is a Pure Wick device available to help kind of collect those dribbles, those type of things? Are we able to keep that environment nice and dry and not constantly moist? Obviously, if they are using Depends or diapers or even the incontinence pads, are we changing those out frequently enough? We don't want those things to stay moist constantly, and that's where I honestly am a little concerned about the Pure Wick down the road. Because I think certain facilities, they just have you change those out every 8 hours, or maybe it's once a shift. I do worry that over time that is going to itself cause some skin issues. And obviously prevention is key. If we are urinating enough, if we are wiping front to back, and we are avoiding those high moist areas, we obviously are hopefully avoiding that skin breakdown. Now, specifically for urine retention, if we are able to identify that we are having an issue with retention, and we are immediately able to treat whatever that situation is, whether it is a prostate problem that's causing that urinary retention, or is it an education thing? As an individual, I just think of a child. It is a school-age child that's not wanting to fully empty their bladder, or is there something mechanically going wrong that's not able to let them void? Obviously, remember when we're dealing with urinary retention, that bladder can only hold so much urine. So in certain cases, when we're doing those ultrasounds, if we see that this individual already has roughly that 2 cups of urine sitting in that bladder, even after they've tried to void, this is obviously a huge issue. We obviously may need some sort of indwelling catheter or intermittent catheterization. Unfortunately, with some individuals, especially I think of the male population, with prostate issues, sometimes we do send them home and they actually straight cath themselves. Or I think of the individual that might be like a paraplegic, wheelchair bound, that may not have feeling anymore below their waist. Those individuals will have to get them on some sort of schedule, and they will know that they have to use a straight cath whatever their protocol or whatever has worked for them, whether it's every 2 hours they straight cath themselves in order to properly prevent that retention or over distension. Obviously, if there's something that we can pinpoint, like that prostate problem, or if there's an underlying problem with the bladder not being, because of that pelvic floor not being anatomically where it needs to be, we can obviously do some surgical things to fix that. I do want to, on this chapter specifically, with that elimination and that first part of that elimination chapter, that module 5, I do want you guys to review those lifespan considerations for both the incontinence and retention. So you may have to go into that example or just kind of see those specific population groups and kind of some unique features about what we would maybe do for those particular individuals, of course, because we've got individuals from infant all the way to our elderly population. Pharmacology. So if you guys were in Blackboard and printed out your VidGrid notes, you would have also noticed I have made you a medication list to know from all the content for Unit 2. So some of those items I've listed here, but for test purposes, I am only going to test you on the ones off of that medication list I'm providing for you. Please note that medication list is just a list of names. I have left space for you guys to actually physically write in the definitions of those meds, side effects, generic names, pertinent details a nurse would need to know, labs you would need to check. So really make sure you do know those meds that I have provided that list for. Those will be the meds to expect on your next exam. So roughly, we do have a good chunk of variety of different medications. This is in table 5.1 in your in that module chapter. So some of these first ones, antidiuretics, they minimize our fluid loss by preventing urine production from the kidneys. So these first meds are for our incontinent patients. They can obviously help retain more urine, or that slows the production of urine. We've got our diuretics that can increase urination by increasing urine production from the kidneys. We have our anticholinergic that do work a lot with those that have urge incontinence. Duloxetine works more with stress incontinence. Estrogen can help with more of like the stress or urge incontinence. We've got some alpha blockers that help more with the BPH, and that's more of like the shrinking of that prostate, so we don't have what we consider the overflow incontinence. Obviously, we have antibiotics that can treat urinary tract infection. And then for those that have like an overactive bladder, that anabutanine, that is not one of the drugs I expect you guys to know. I'm just voicing this because it is in your book there. Some retention meds do include cholinergics, some anti-anxiety meds. As you guys can see, there's are a lot of antidepressant type drugs, or psychiatric almost meds. So if you guys notice, these aren't just like meds that are just going to work with the kidneys. So probably the main common theme about these retention meds is think of these drugs as drying your system out. So we're not retaining as much urine because it's kind of drying our systems out. Obviously, if we are having issues with our muscles relaxing, muscle relaxers obviously are appropriate for individuals with that retention related to relaxation. And histamines kind of help dry things out. And of course, if we are retaining a lot of things, we may develop, or a lot of urine, we may unfortunately develop a bladder infection. And so that's why we do list antibiotics under this side as well. Some other collaborative pharmacological therapies I do want to mention. I do want to touch on anticholinergics real quick for you. Anticholinergic medications do reduce urinary frequency as well as that incontinence. Cholinergic medications promote the excretion of urine, so that's why that they're on the retention side. Antibiotics obviously treat our infections. We can have urinary analgesics for patients that have different types of cystitis or pain with urination. And then we have antispasmatics to hopefully treat those spasms. And then, of course, to help promote urination, we do have our diuretics, which include our loop diuretics, thiazide, potassium sparing, carbonic hydrase inhibitors, or osmotic diuretics. So again, just make sure you know the ones I have listed in your Blackboard for Unit 2. It is not every drug that's in that table on 5.1. So don't be too alarmed. When you see the list, you'll be like, okay, it's not that bad. All right, we are going to switch gears here and talk about our gastric system with the concept of elimination. Obviously, a quick review. So that GI tract works with our gastric organs of that digestive system to obviously digest our food and drink. Peristalsis, it is that muscle movement that helps move our food from the stomach through our intestines in order for us to expel out. With our small intestines, their primary function is for food and liquid do mix with that digestive secretions from our pancreas and liver. The small intestines do have peristalsis that does help move the nutrients and food through to aid in that transportation of food through that GI tract. That small intestine is a lot of where our absorption of those nutrients are actually coming from, is in that small intestine area. And then our large intestine is where liquid is absorbed from the waste byproduct, and we usually pee that out, or the stool is actually formed, and then peristalsis obviously continues that muscle movement throughout to push that formed stool out through our anus during a bowel movement. Okay, so bowel elimination. We can obviously have frequent, obviously it's important to assess frequency and volume of an individual and the consistency. Are we talking about formed stool? Are we talking about liquid stool? Factors that can affect our bowel movements do include our diet. Do we have adequate fiber to help contribute to the bulk of our stool? Are we able to have adequate water intake, fluid intake in order for the stool for us to not develop constipation? Do we have adequate activity, or is this person completely bedbound? I would expect an individual that might be bedbound to maybe have some constipation issues going on because we aren't having that movement and activity to kind of get our gut going. Do we have adequate bathroom habits, or are we dealing with pediatric patients that are having issues with incontinence, or where they were at one point potty trained, or do we have individuals that have maybe had a motor vehicle accident and we've lost connection with their lower half, or like the paraplegics where we may not have adequate control of their bowels anymore. Medications obviously can play a factor into either making us constipated, or for example, if we're giving lots of antibiotics, kind of killing off all that healthy flora in our gut to then lead to diarrhea and possibly C. diff. Anesthesia, just like the anesthesia can affect our ability to urinate after surgery, anesthesia can also cause us to have constipation as well, because when we are under anesthesia, everything is asleep. So we have to kind of wait for that gut to wake back up in order to eat, etc. We can have some other pathological or maybe some genetic conditions, pain, or psychological factors as well that can contribute to our ability to have proper bowel elimination. Alterations in bowel elimination are usually treated or manageable for the most part. Nurses can assist clients with making lifestyle changes. So if you have an individual that is just a diet issue, we can also encourage them to pick from high fiber foods, making sure they, I always think of the little, like my Nana, the elderly little lady that drinks her 1 cup of coffee all day, and that's all the fluid she's taking in. She's going to need some water in her diet, regular drinking of fluids, so that way she is not having issues with the constipation. We can obviously provide some bowel training if we are dealing with patients suffering like motor vehicle accidents or surgeries, things like that, where we're trying to retrain muscles, things like that, to signals to the brain to be able to either help control the bowels, their bowels. And then obviously we can, for those individuals that we are struggling with the constipation, we can obviously provide certain medications, things like that, to help kind of stimulate those bowel movements, as well as just exercise, getting those patients up at a certain point when they're able to walk, and it's permitted for them to walk by the physician. getting them up and doing their laps around the nurse's station. So that way we can hopefully have a bowel movement as well on a regular basis. Okay, some other factors that do obviously influence those a little bit more detail here are elimination, our bowel elimination, use of elimination aids. So when I think of elimination aids, I think of things that maybe your grandmother would tell you in order for you, if you're having constipation, these are some tricks or things that you could do. So there are things like eating dried fruit, eating your prunes. Their examples are certain foods or fluids like hot lemon juice before breakfast, the use of laxatives or enemas to maintain elimination or in order for us to eliminate stool. Is it okay for us to use laxatives or enemas on a regular basis? No. Now, if this was somebody that maybe was a paraplegic that is unable to now feel or control when he or she has bowel movements, I could maybe see that they may need that assistance in order for them to not have constipation. Diet obviously is a huge factor. What can you eat to obviously help support our GI system? Those are foods with high fiber, as well as getting appropriate water intake. Exercise again. Obviously, exercise can mean so many different things for some individuals. Do I expect an individual that does not run on a regular basis, do I tell them that they need to run a mile every day? Obviously not. So we might need to have to pick some different activities that permit to that patient and their limitations. Water aerobics, for example, with our elderly population, it might be better and easier for them to do something like that for their exercise versus running a mile every day. Just, quick example here. Medications, obviously, we can to help support our healthy guts, things like probiotics, especially for those patients that are on antibiotics. I think physicians have gotten, especially those that have Texas Tech physicians, they have gotten a better grasp of probiotics for our gut health. And those individuals that we have on some massive IV antibiotics like vancomycin, things like that, we're going ahead and giving them oral probiotics to hopefully counteract those antibiotics, completely wiping out our good bacteria in our gut, so that we hopefully we don't encounter C. diff, things like that. Stress, obviously, certain amounts of stress can obviously affect our control of our bowel system. I think of that toddler age, this might be where we see some regression. I think of, I'm probably embarrassing my oldest, but she was 2 at the time. So I think of when we brought home her little sister from the hospital, we had a little bit of some regression with potty training, in particular, her being able to expel stool. She ended up having some issues with constipation. And it's just, that change in the environment, the emotional shift of her being the single child to now she's having to share mom and dad's attention with a new sibling. That shift there does happen. So it's not completely abnormal for us to see certain regression, but should we be concerned if we have a 12 or 13-year-old school-age child all of a sudden having regression of bowel things, whether it's incontinence or major issues with constipation? Yes, we may have to look into more psychologically what could be going on. Are they experiencing some sort of trauma of child abuse, for instance, or is this more of like a stressor? There's something significantly going on in school, anxiety, whatever it is that could be causing the abnormality. Okay, so our nurse's role, again, with our bowel elimination, assessment is always that first step. I hope that we have really, how did you guys, when you guys did your head to toes, when we are doing the GI system, what are we doing when we get to the abdomen? We need to first look, listen, and then palpate, right? So make sure you guys keep that knowledge, keep pulling that forward. making sure that we are properly assessing all 4 quadrants when we are doing those, when we are listening to our patients and performing our daily assessments on them. Some other diagnostics that we would use in healthcare do include barium enema, as well as a sigmoidoscopy, which is more that lower GI tract, where a colonoscopy is the full intestines. So a sigmoid is only just a small portion of the intestines, and then that colonoscopy is the full intestines. Though obviously we put a camera up there after we've done a bowel prep, so that way the physician can actually go in there and see what is happening in the gut. Do we have any abnormalities within the lining of the intestines, things like that? Do we have polyps, or are we concerned of cancer? Those type of measurements. There is parameters, there is in the exemplar over bowels. I was trying to find that page. It had a really good some pictures of what some abnormal findings would be like on a colonoscopy. I'm not going to test you on that specifically, but just as you guys are learning about everything, and as we start working with patients in clinicals, we may start talking about some of these disease processes. Sorry, I thought I had saved that page. Let me flip to it really quick. Okay, so those pictures of those different, when we're talking about some different abnormalities with our intestines, is on page 312 in module 5. It is in that first intro to the concept section, and it is figure 5.4, and it shows 4 pictures of some abnormalities that we would maybe see in individuals. That first one is adhesions. Those are just abnormal line. There is something wrong with the lining of our intestines. The herniation is where that bowel will actually poke through our muscle walls, especially in that abdomen. Then we have intussusception, which can be a complication, unfortunately, in infants, really young infants. I would say up to maybe a year old. And then volvulus is where we've got that twisting. These are obviously very serious issues with each one of these. I would say the volvulus, when we're twisting those intestines, the biggest thing we're concerned about is a complete obstruction of the bowel, and then necrotic bowel to develop, where we are having to completely cut out that section of the bowel because it died. So those are just some things to kind of keep in mind. I'm not going to quiz you on each one of those. Just know that those are unfortunately the consequences if we're not able to properly treat our individuals, or these might be some things that we will see in the clinical setting of those that maybe have complications regarding their bowels. Clinical manifestations and tables. Look at that table on page 353. Really look at those therapies or interventions. Medications, again, I have put on that unit 2 medication list some medications that relate to bowels, being able to either have bowel movements or be able to stop diarrhea, as well as medications that we use to treat C. diff. So know those. And then obviously, just like when we're doing the COCA for our urine, we obviously do need to look at the frequency, color, pain, consistency of our bowel movements. What other education do we often provide our individuals on bowels and elimination? Obviously, dietary methods. We want them to have high fiber diets, drink plenty of fluids, fiber supplements, some behavioral methods, exercise on a regular basis, not ignoring that urge to defecate. So sometimes we'll see that when kids first start hitting kindergarten, maybe first grade, where they're used to being able to go to the bathroom on a regular basis whenever they needed to, maybe in preschool. But now that we're in the school setting, sometimes they're having to hold it, or maybe they are just distracted by things and hold it, and not go to the bathroom or ask for bathroom breaks when they should. And so we might have some issues with constipation. Obviously, we can have some stool softeners and laxatives. Just remember, when we are talking in Cluck's World about stool softeners and laxatives, this is for short-term use only, to only provide temporary relief of passage of stool, but we don't want to use them every day or on a routine basis. On that assessment tables that they do have under the bowel area, I do want to make sure that you guys do look at those alterations and therapies. That is on page 313. And then that abdominal assessment, if you need to review how do we really truly assess our bowels with that look, listen, and feel, that is on pages 315 to 316. So don't be surprised if there might be a situation where it says, what finding would the nurse preceptor see that the student nurse has done incorrectly when assessing the GI tract? And it might have those out of order. It might have them feeling or listening first before they're looking, things like that. And why do we have that order? Why do we really insist that it is look, listen, and feel? Make sure you do understand that. I do want to mention briefly the different, when we're doing an assessment of our stools, we do kind of look for some things. First of all, we see blood sometimes when we have bowel movements? That might be something important to tell a physician, especially when we are on lots of blood thinners. Are we having a GI bleed? Is sometimes that blood microscopic or where we can't see it? Absolutely. So we would perform what we call occult testing, so that way we can see that microscopic blood that might be found in the stool. You can have individuals that their certain medications, I always think of like Pepto-Bismol, makes stools kind of a blackish color. Certain antibiotics, I think of Cipro, can make stools almost like a magenta color. I always think of my baby when we had to put her on Cipro for ear infections. And I always had to warn daycare, it's going to look like they're bleeding, and it's just magenta colored stool for the time frame that she was on the antibiotics. So some other things to kind of just keep in mind are these different types of stools. What is a normal bowel movement? So if you have an individual, especially when we're educating our patients, what is normal when we're talking about bowels? So for an individual, if they're always having these pebble-like stools, for them, they might think that's normal. So we need to be very careful how we're asking patients, are you having normal bowel movements? They might say, yeah, because this is their normal. But is that considered normal? No, not really. So we need to really make sure instead of saying, are you having normal bowel movements, we should say, what do your stools look like? How often are you having a bowel movement? So for them, it might be like, well, once a week I poop. Is that normal? Probably that might be, we would honestly probably worry about some constipation. Now, if it's every other day they have a bowel movement, that's probably okay. But if we're going longer than like 3 or 4 days, that would be definitely something I'd be concerned about for constipation. So definitely make yourself very familiar with this Bristol stool chart. The question I may have on the test might describe a certain stool, and you're just basically have a description of stools, and you're just going to need to tell me, is this a normal bowel movement, or maybe what is going on? So if you have an individual having these little pellet-like stools, you would be looking for the answer regarding this is constipation, obviously, or severe constipation. As well as the other extreme, when we're having that very liquid stools, we are worried about the diarrhea. If we know they have a history of recent antibiotic use, we would maybe even question, could this be C. diff? Okay, so moving on to those interventions and collaboration therapies with our bowels. Some independent nursing interventions. We obviously want to encourage that increase of fluid and fiber, teaching them about our dietary choices. If we're only eating junk, that can often lead, fast food, that can often lead to that constipation, because we're not getting our fruits and vegetables that our small intestines need, those appropriate nutrients to then support the rest of our body system. Are we getting certain exercise, even pelvic floor exercises? Maybe for those that might be having some leakage of stools, things like that, it is a muscle issue or a sphincter issue versus C. diff, if that makes any sense. So you might be having some leakage due to that, or is the leakage due to impacted where the stool is so hard that only like liquidy stool is able to get around the blockage? Personal hygiene, are we properly cleaning? front to back, especially because we don't want stool to get in our urethra if we're a female, causing an infection. And then even those, unfortunately, with ostomy, are we properly taking care of that ostomy? For you guys in nursing 1, I'm not going to go deep into ostomy care, but I am going to show you guys just a quick video, just so that way if we do have a patient on the floor that does have an ostomy, kind of for those of you that might be a little bit more green and haven't been around patients with that, you're not so surprised, and you'll know maybe what we need to do, how we empty the bag, things like that. So let me quick pause this video as I get the big one open here.
In this video, we're going to talk about stoma care. Now, the wafer and bag for an ostomy only needs to be changed every 3 days or if it's leaking, but you still need to be able to assess the stoma itself. So in this case, we're going to show you how to replace the bag and clean and assess the stoma. So you want to start by putting a towel under the patient on the side of the stoma. And then the first thing you want to do is assess the output from the stoma. So if you have a clear bag, you can actually see the output through the bag and visualize it that way. Otherwise, you'll need to empty it. In order to clean and assess the stoma, we have to remove the bag. So start by peeling the wafer and just pushing the skin down away from it gently. You might need to use warm water or alcohol here if the adhesive is tough. Now you want to clean the stoma and around it with a washcloth with warm soapy water. Just use gentle strokes. You don't want to scrub. Then you want to pat the skin dry with a towel. Again, don't rub, just pat. So
I will tell you the other tip I've had as a nurse is, depending on where the ostomy is it in their small bowel or their large bowel? If it's the large bowel, I usually don't see so much like liquid leaking out of it, so I don't worry about it just oozing out the whole time. Now, if this ostomy is more and that's their small bowel area, I honestly would keep some absorbent gauze or that wash rag pretty much on that stoma until I'm completely done prepping that skin, because what's going to happen is we are not able to turn it off. So if there is liquid stool, it's going to continue to ooze out as I have that bag off. So just so it's not getting everywhere, I like to put some sort of towel, wash rag over that area, a clean one, of course. And then right when I have almost everything completely prepped and ready, I'll do one more quick wipe of that region, very gentle again, and then I'll go ahead and adhere the bag back on. So that's just one thing. I don't know if she actually talks about that in this.
Now that the stoma is clean, you can actually do your assessment. So you want to inspect the stoma itself. It should be light to dark pink and moist. What you don't want to see is dark red, pale purple, or any kind of bluish color. None of those are good signs. They all represent problems with perfusion and should be reported right away. And of course, look for any skin breakdown. So now you want to measure the stoma and cut the hole of the wafer to be about 1/8 of an inch larger than the stoma. If it's too small, it can actually cut off circulation to the stoma itself. So you're going to use a pair of scissors to cut.
And then if we cut too big of a hole for that stoma, we will have leakage of stool around that stoma. So if, that can cause some skin breakdown. So you just really, the biggest key when we're talking about ostomy care is the proper adherence and the proper fit of those bags. We don't want them too loose. We don't want them too small where it's cutting off that circulation, and we just don't want this. Monitoring that skin breakdown of that area is extremely vital.
Around the inside hole of the wafer. Now, some wafers, depending on the brand you have, some of them have little measurement tools, some of them don't. So just make sure that you are about 1/8 of an inch larger than the stoma itself. If you need to, apply skin prep or barrier to the skin around the stoma, and then remove the backing from the wafer and apply it to the skin with the stoma in the center of the hole. Now, for patients who've had a stoma for a long time, they may have a preference here of which angle they would like their bag going. Some of them like it going straight down, some of them like it going off to the side. So just make sure you talk to your patient about that. Now, as you're smoothing down the wafer, if you do get any creases that you can't smooth out, you can use a barrier paste to fill that in. If you're using a 2-piece system, apply the wafer first and then snap on the bag. Just make sure the bag is closed and sealed based on whatever type of bag you have. Discard your supplies, wash your hands, and document your findings. Make sure that you include this in output measurement as well. So that's it for stoma care.
Okay, so I hope that at least was familiar. I didn't know how far Ms. Monterey went into detail. I won't really be testing a whole lot on ostomy care, but just know for NCLEX purposes and as you guys move up into the levels. And as we interact with patients that have these, the biggest thing is just that the skin integrity around that ostomy area, and are we maintaining that properly? Again, I have listed the medications that will relate to the elimination of our bowels in that medication list for you that is posted in Blackboard. Make sure you do know the ones I have listed there for you. There are med tables in this module chapter. Those can be found on med table 5.2. That is roughly pages 318 to 312. Some of those major ones are laxatives, stool softeners, anti-diarrheal agents, and then I also tied in some medications to help those with C. diff, what medications we use for C. diff. Some other, obviously, therapies, collaborative therapies that we can obviously do for individuals. We may need to do surgery or procedures to counteract that obstruction. Individuals that may have an ulceration, purification, which just means an opening in the intestines, and then maybe those that do develop cancer. We obviously have to treat those individuals. I do want you to read through that lifespan considerations for the bowel elimination, just like you did for the urinary elimination as well. So moving into the nutrition side, the VidGrid portion of this nutrition side is just going to be, you will actually cover nutrition in level 2 next semester. So I'm only going to just introduce the concept of nutrition for you. I'm not going to dive deep into carb counting, anything like that, because that is more what you guys will talk about in nursing too. So really, when you're trying to narrow down what you should be reading in the chapter, go off of what I talk about in these lectures and the VidGrid, as well as our lecture on Wednesday. And I want you to narrow your focus on those sections of those chapters. Okay. So for this first part, this is, of course, the introduction of nutrition. So nutrition is that process by which our body ingests, absorbs, and transports, uses, and eliminates nutrients in food. Our antecedents, this is, remember those, what we obviously need for our body system to be functioning properly with nutrition is our normal GI tract, as well as our associated organs that are involved in nutrition. Adequate ingestion of our nutrients and water, normal temperature, body temperature, and normal pH. Obviously, I'm hoping you guys remember from A&P, our gastric or stomach contents naturally should have a higher pH balance, and that is to help break down food so that way we can absorb those nutrients. Some attributes that do relate back to nutrition is we need adequate intake for the development of energy, growth, and tissue repair is what we use our food intake for. We obviously hope we have an ideal height, body weight, or what we call a BMI. We want proper muscle tone, strength, and agility, so that way we can have that proper peristalsis. We aren't having constipation, things like that would back up or interfere with our nutritional intake. We need cognitive and mood appropriate responses. Especially when I think of that, I think of our Alzheimer's patients, or those maybe with dementia. Are they forgetting to eat? Are they remembering to go get groceries? Things like that. We just obviously need that to be cognitively intact, or have appropriate IADLs and BADLs in order to be able to support nutrition. We want our albumin and protein intake to be within normal limits. Obviously, our hemoglobin hematocrit to be within normal limits, and obviously our electrolytes. So we need everything to be, our nutrition to actually be supporting those normal body systems and functions. So what is the role of digestion when it relates to nutrition? Obviously, digestion does break down food in order to utilize nutrients to support the health growth and maintenance and repair of our body. Digestion does involve our GI system. This is on table 14.1. It breaks down each of those organs that are within our digestive tract. The first is the esophagus. I'm just going to quickly read the words. I want you guys to really focus on the definitions of these, and that's part of what is going to be on your ticket to class on Wednesday. I will maybe be expecting you to match which organ matches to the job. So we've got the esophagus, stomach, liver, gallbladder, pancreas, small intestine, large intestines, the rectum, and then the anus. So I do want you to read through that table, really make sure you do know what each of these organs or glands have to do with our digestive system. Factors influencing nutrition do include our ability to taste, smell, certain habits or the availability of food, the appearance or packaging of food. Does it appeal to us? Is there a connection, emotional connection to food, body image, health, and cultural, I wouldn't say cultural regulation, but cultural traditions that affect certain foods we can or cannot have due to our cultural beliefs or cultural practices. Some other factors do include our food choices. This can include the ability for people to read. So you may have an individual that is not able to read English. Maybe they read Spanish. Are they able to read labels and know that this item is high in protein or know this item is high in sugar? Are we able to read food labels? Are we able to then, when we're at the grocery store or when we're analyzing what we should be eating, are we able to determine whether our intake is appropriate? Are we able to also be able to relate what we're eating to, is what we're eating contributing to a disease process? For example, are we eating lots of carbs? Do we understand that eating lots of carbs contribute to high blood sugar? That does contribute to an individual that has diabetes, and it will fluctuate their blood sugars. Where if they have more protein with their meals, it kind of helps keep that blood sugar more regulated and helps contribute to a more stabilized diabetic. So food, I do want to mention something called food security. This is more about our ability to adequately and appropriately obtain food. Do we have enough of the financial means, knowledge, and ability to actually go and purchase food? Is there local stores? Is there markets nearby? Or are we in the middle of nowhere in Alaska and we only get to go to the grocery store once every 6 months? Just things like that. So when we are talking about food security, below underneath your slide, let me show you guys. So just underneath this slide on your guys' printout is another whole information just on food security. I'm going to read through that real quick with you guys. It is important to know this, especially when we're talking about the socioeconomic status of our patients. So food security means having at all times, both physically and economical access to sufficient food to meet dietary needs for our proper health. A family is food secure when its members do not live in hunger or fear of hunger. Food insecurity is often rooted for those individuals that have trouble with poverty or that ultimately has a long-term impact of their ability to develop properly. Prolonged undernourishment can stunt growth, it can slow cognitive development, and it can increase susceptibility to illnesses. So those that have food security, we consider that high food security is an individual that has complete and full access to food. They don't have to worry about what food costs. They can go to the store and spend several $100s and not even think about it. Then you have somebody that might have marginal food security, where they may have maybe some anxiety over food security. So maybe they have some adequate funds, but that they still, at the end of the day, may worry about are they able to wait for that next paycheck in order to get their groceries. They may be able to then be able to afford it, but there is maybe a timing factor that they have to maybe say no to some other things in order to get their food. Then we have individuals that we consider food insecurity. These are individuals that have that report a reduced quality, variety, or desirable of diet. They may have low or no indication of reduced food intake. So this might be the individual that maybe this is how they were raised their whole life. Maybe in a rural area, maybe even in a big town where they just know that they only have X amount of dollars to spend, and so they're used to only maybe being able to buy groceries twice a month because that's when that paycheck comes in. So they will make the best of what they have. Is it high quality or fresh fruits and vegetables? Often not, because a lot of times, unfortunately, with our economic society today, those healthier foods, healthier options are very expensive, where like the canned goods, processed foods, they seem to be a little bit cheaper options. And so individuals may choose to pick the unhealthier things because they are cheaper. Whereas if they are just in the fresh fruit and vegetable area, that does seem to be almost wasteful sometimes, because you spend a lot of money on these products and then unfortunately those foods don't last a long time, where processed food seems to have better shelf life, things like that. Individuals that have low food security do report multiple indications of disrupted eating patterns that do reduce their food intake. We do worry about those that have the very low food insecurity. Our biggest thing that we worry about is malnutrition. Some examples are parents will go hungry so the children have food. Insecurity is higher in summer months because kids don't have the free lunches or lunch programs. I do feel like our area thankfully has it's not called Pack-a-Sack. The programs that they do offer during the school year, where they do provide certain families with the packed backpack that does have some nutrients and some food items to get the kid through the weekend until they can come back to school. I know COVID, they were offering free lunches that parents could or caregivers could drive through the school parking lots, and they would have lunches made for kids. When the school systems did shut down, they were able to provide some school lunches to kids in those certain situations. I also think of the college age student. This can be roughly between the 20 to 40% of college students. And I'll be honest, I honestly probably was one of them. I would live off of ramen noodles and whatever was very inexpensive, because the meal plans that the WT offered for their cafeteria were extremely expensive. And so I would choose to eat cereal for dinner. I mean, this is back when I probably weighed nothing, but unfortunately, this is some things that individuals do face. You just don't have that adequate income from jobs, because it is hard balancing school, things like that, in that college age area. Other areas of population I do consider, or I do worry about that very low food security, includes our geriatric population, especially those that might be very isolated. Maybe they're living by themselves. It can be hard for them psychologically, and it can be hard financially for them to go to the store when they're only just cooking for one, things like that. Obviously, there may be a reduction in physical ability. Maybe they're not able to go to the store anymore, so they have to rely on other individuals shopping for them. Maybe they have a child that goes grocery shopping for them once a month, and they just have to make do with whatever was purchased during that month. And a lot of these guys are on fixed income, so they may only be able to get X amount of food for what little bit of money they have coming in from Social Security. We may worry about those with that diminished mental capacity, such as those with Alzheimer's or dementia. They really do honestly forget to eat, or maybe we can get them in an environment like a nursing home. We have a lunchroom environment where they can sit and eat, but they will forget after they've been sitting there for a short period of time and then get up and walk away. So for some of those individuals, we have to physically hand them things. Like we have to give them Ensure to drink, and you have to make sure that you watch them take a couple sips of that Ensure, or you give them a cheese stick because they do like to wander often. And then, of course, those that maybe just have that lack of transportation, those that maybe are unable to drive to the store, or like I was saying, if you're in a rural area such as Alaska, you may not have a grocery store around the corner to provide those adequate options for you. Balanced diet, just real quickly, obviously we want individuals to have a healthy and balanced diet. We would ideally would love this if somebody would eat this on a daily basis, watch their calorie intake, and consume a variety of nutrients. So I don't know if any of you, when you grew up in grade school, you were taught the pyramid, and these are the recommendations for the food. Now we teach what we call the My Plate, and as you guys can see, it is more of an equal amount of everything. It's not just all carbs on the bottom like it used to be. We really do want a proper balance. Ideally, we want a little bit more fruit and vegetables. We do want some good protein, and we do want a balance of some adequate carbs, as well as including dairy. As you can see in this My Plate, there is no option for fats really or sugars, so that's just always recommended to use in moderation. This part of the chapter, I'm not expecting you guys to read in depth about macronutrients or micronutrients. That will be more for nursing too, when you guys are talking about carb counting, things like that. But I at least want you to know that there are two categories of nutrients and kind of how they're broken up. So with our macronutrients, these are our carbs, fats, and proteins. Micronutrients to include our vitamins, minerals, electrolytes, and water. And then with this next slide, I tried to put everything I could, roughly a quick outline of a breakdown of the nutrients in our body system. So why do we need carbohydrates? Obviously, they supply us with energy, convert. It's important to remember that carbs do convert to sugar in our system. Primarily, carbs do come from plant-based foods. I think of potatoes, things like that. Insufficient intake of carbs can lead to tissue wasting because our bodies it needs those carbs to burn energy, and if we don't supply appropriate carbs, we will actually have a breakdown of protein and muscle. That's what's popular with the keto diet, is that you are not taking any protein in, or sorry, you're not taking any carbs in, and so the body doesn't have anything else to waste except eventually the fat and protein in our system. I personally don't believe it is something that you can maintain over a long period of time diet-wise, because for some individuals it can lead to that metabolic acidosis from excess ketones from that fat breakdown. Can it sometimes supply individuals with a quick way to lose some weight? Yes, I've seen that before, but is it something that I see individuals being able to maintain year after year, or is it healthy because of that risk for that acidosis that on their body system? Lipids, of course, I want you guys to always think of fat when you see the word lipid. This is kind of that secondary source of energy. We do need fat in our diet because our body itself needs some pockets of fat for body protection. I think of, especially with our elderly population, as we age, as their diet changes, they may not be getting adequate or healthy fats in their diet. Oftentimes they will have the wasting areas, and we need some of those pockets of fat to protect hips, things like that, when we would maybe possibly fall. Triglycerides, saturated and unsaturated fats are obviously important to monitor. Are we getting the healthy fats versus the unhealthy fats in our system? Because obviously those unhealthy fats can lead to elevated cholesterol levels. Protein does consist of amino acids. It is essential to support our body's function. Protein is really important for new growth of tissue. It does promote growth, healing, and overall body maintenance. I also see individuals that are struggling with skin breakdown, things like that. They are often also not getting appropriate protein in their diet. Vitamins do help regulate our body function. They must be consumed as part of our daily intake, except for vitamin D and K. We don't need those necessarily on a daily basis unless we are deficient in vitamin D. Fat solubles and water solubles. Fat solubles are stored in our liver until we need them. These are not excreted through our kidneys. These do include vitamins A, D, E, and K. And then we have our water-soluble vitamins that is excreted through our kidneys, vitamins B and complex, vitamin B complex, and then C, vitamin C. Our vitamins can be absorbed with water in that GI tract, and then those water-soluble vitamins are excreted through our urine. Vitamin C is especially significant in tissue healing. And obviously, those individuals that we are wanting to stay healthy, if we have, for instance, like my whole family members, all my kids and my husband all came down with basically a cold over spring break. And I tried to increase my vitamin C to hopefully avoid catching it, as well as just supporting my immune system if I did come down with that cold. Below this area on your guys' printout, this is below that slide. The other areas I wanted to make sure to just briefly cover with you guys are minerals. This includes our salt that is essential for our body system to function. It does help regulate, obviously, our electrolytes. It does help maintain that fluid balance. Calcium is our most abundant mineral that is needed in our diet. It does help with, obviously, our bones and teeth development. And then phosphorus does participate in energy production and helps support that buffering system. And then last but not least, our water intake. Obviously, we talked about fluid electrolytes in 1128. I don't know if you guys remember those numbers of roughly how much of our body is made up. For adults, it's roughly around that 60%. Infants, it's roughly around 75% of our weight. Water is essential to help transport nutrients and then helps expel waste through urination as well as stool. Water is important for our metabolic processes and temperature regulation. It does add as a lubricant, cushion, and it does help regulate our body temperature, blood volume, and assists in maintaining our healthy weight. Diagnostic tests that we can use to kind of help assess where we are nutritionally for patients includes first that lipid profile that does help check our cholesterol levels. Roughly our total cholesterol levels should be between 160 and 200. We use the CBC. We talked a lot about this in that sim that we did in clinical orientation. For those that we are concerned about anemia, especially iron intake, we would definitely watch our hemoglobin and hematocrit, that we would be looking for blood loss or iron deficiency. Serum glucose, we are checking for those that maybe have diabetes, hypo or hyperglycemia. Serum albumin, adequate protein intake. Serum vitamins do include those B12 deficiencies, and then I briefly mentioned the vitamin D deficiencies. Nursing roles and interventions. Nurses play a vital role in educating our patients about food choices. You don't need physician orders to tell a patient that that's not an appropriate item for them to select on their menu for their prescribed diet. It is also okay to educate patients on health promotion, recommending, increase in fiber or cutting back on sugar, things like that. We don't need physician orders to tell us to do that. That also includes kind of that management of our illness or disease, such as diabetes, or if you have high cholesterol, things like that. Nurses also assist in providing weekly weight measurements, sometimes daily weight measurements, depending on the situation, and evaluating a patient's diet. Are we able to kind of ask the individual to kind of keep a diary of what they're eating, and then are we adequately able to kind of glance at that and notice there might be a trend of there's a lack of fiber, there's a lack of protein, or are we eating too many carbs? Can we get more of a balance? We can ask for nutritional consultation or nutritional counseling for individuals, dietitians. We can obviously ask the physician to implement some orders for those, so that way they can get that very specific help that they need regarding their disease or their whatever is happening to them. And then recommendations for other online resources, community programs. I think of like Meals on Wheels for those that are kind of isolated or living alone. especially in our elderly population, can we help set them up with a program like that? Do they need support from like the food banks, things like that? Can we give individuals addresses, names, numbers of where to go to get proper nourishment? Weight management, we can kind of talk about that as well, and then just healthy eating in general with our patients. Some more of the collaborative interventions do include those consults or referrals, and this is where we would talk to a physician about getting some orders for these. These can include obviously a dietitian, nutritionist. We can, in the healthcare system, physicians can refer to weight loss clinics, personal trainers even. Some of that personal trainer thing can just be obviously advising that a patient is stable enough that we are recommending that they do participate in some sort of physical activity. I know some certain gyms, I think of Silver Sneakers, have different programs for specific age groups, different population groups, to kind of assist with very specific exercises for certain populations of people. I think of the geriatric population. We can obviously recommend occupational therapy or physical therapy if it's I think of the stroke patient, if we're having trouble with occupational type therapy issues, swallowing, weakness on one side or the other, not being able to hold our forks like we used to. Are we needing tube fittings? Things like that. Physical therapy would be more, are we adequately able to perform some things like being able to get up out of a chair, being able to sit up in a chair to eat? Are we able to walk to the refrigerator? Are we able to stand to cook? Things of those natures. Non-pharmacological interventions do include weight loss recommendation, diet changes, nutritional supplements. For example, athletes, we need to often recommend that they are getting adequate calorie intake because they're burning lots of calories. This can include obviously protein intake. And then they're going to need some calcium as well to kind of contribute to that bone strength. We don't want there to be muscle breakdown, especially with our athletes. And we do worry about hydration as well. I don't have that listed on here, but I forgot to add that. With our athletes, we worry about their adequate electrolytes and hydration. So we need to make sure that we are recommending replacements if they're needing Gatorade, things like that, after a sporting event or whatever it is. Obviously, it is important to note we do often recommend supplements to patients, but when I usually talking with patients, even my own parents, I'll tell you guys a story in class on Wednesday about my own parents having issues with taking too many supplements and some consequences they faced from that. But so usually whether it is a pediatric patient or an adult, I often will tell those individuals you really don't need, unless a physician has specifically been able to measure a certain vitamin that you're low on, let's say it's vitamin D, you only really need just a basic multivitamin according to whatever age you are. So like a pediatric multivitamin is obviously safe for a child to consume on a daily basis, as well as adults. They just need that one a day multivitamin. We don't need to excessively go into 5 different bottles of different vitamins because our body doesn't need it. Eventually it will either excrete it, or I'll tell you about some consequences that will develop from the excess of those supplements. We can obviously, when we're talking about nutrition and maybe obesity, we worry about those that have morbid obesity. We can do surgery to obviously correct or help modify their lifestyle so we can lose some weight and maybe correct some other underlying health issues or diseases. We do that through bariatric surgery, lap band surgeries, and this is only a very specific group of patients. They have to meet certain BMI criteria. They have to pass nutritional and dietitian education classes, and they have to also meet with a psychiatrist to kind of see if emotionally they're able to cope with the new lifestyle that these procedures actually will cause. And certain other GI surgeries, if we were talking about the ostomy before, if we're having trouble with our ability to expel stool, things like that, that obviously can affect our nutritional intake, or the individuals that maybe need special feeding tubes, peg tubes, because they're not able to digest food like a normal individual. And then weight loss injection is another really big trend right now. The semaglutide injections, like Ozempic, for example, these are some new things that they have developed to help combat those with diabetes, contribute to some healthy weight loss for those individuals to hopefully help bring them back more of a holistic homeostasis type care where they're able to regulate their blood sugars as well as lose maybe some excess weight and control that appetite, so that way we are able to regulate the diabetes more efficiently. Do we see individuals, movie stars, using semaglutide injections, things like that? Yes. The patients I have seen in the real world using this, the physicians are properly, and I will never judge an individual for whatever choice they're using these injections, but when I see it prescribed in the real world, it is for usually diabetes or coronary artery disease risk. We're needing to kind of control weight gain, things like that, and maybe adapt that individual for a more healthier lifestyle. I don't know if we have enough research on these drugs to know ultimately some of the significant side effects or long-term consequences of these drugs. I do know we do have to watch their blood pressure medications when they start losing some of those big numbers of weight. Obviously, we can cut down on some of those blood pressure medications. So what we'll often see is an individual having hypotension, passing out, things like that, from their body no longer needing those higher strength doses of blood pressure medications, and we're having to adjust, which is a good thing. We're having to adjust how much medications we're giving them. Or those that might be on insulin or something, or not adequately getting enough sugar in their diet and having hypoglycemia from the semaglutide, similar to what a patient on insulin would be. We just have to find that happy balance for those individuals. In general, that is it for this recap of that elimination and nutrition vid grid for you guys. I want to make sure that you guys bring your nursing skills book, because we are going to look at the different charts in that book that cover the different diets that we will see in the hospital, such as clear diet, full liquid diet, things like that, so that way we can really understand what those diets are, what's appropriate to give those patients, especially as we approach clinicals here in the next week. So thank you for your time, and I will see you guys on Monday.